Docplexus. Welcome to a brand new session of the Master Series webinar. Herpes simplex keratitis is the leading infectious cause of corneal ulcers and blindness worldwide. It affects 149 per 1 lakh individual in developed countries. The occurrence is even higher in less developed countries. Herpes simplex keratitis can progress to corneal perforation or blindness if left untreated. However, innovations in antiviral therapeutics can ensure the effective treatment of active infection and the prevention of latent infection. To tell us more on this, we have with us today Dr. Chintan Malhotra, and moderating today's session is Dr. Rakesh Gupta. Dr. Chintan Malhotra is an additional professor at Advanced Eye Center at PGIMER, Chandigarh. She is a proficient ophthalmologist who has about 65 publications to her credit. Her area of expertise include LASIK, optical coherence, tomography, myopia, glaucoma, and astigmatism. Our moderator for today is Dr. Rakesh Gupta, who is the President and Director of Public Health, Sipher. Dr. Rakesh Gupta is the former Director of Health Services and the Director of Chemical Examiner Lab, Punjab. He holds a vast professional experience of 35 plus years and 8 plus years of expertise in managing the national non-communicable disease programs, especially blindness control, tobacco control programs. He is an alumnus of the Johns Hopkins School of Public Health. We welcome you to docplexus. It's a pleasure to host you here today. You may begin with the session.
So dear viewers, I am Dr. Rakesh Gupta, President Sipher and former Director of Services Punjab. We welcome you all for a webinar series by docplexus. This is a special presentation on viral keratitis, and we feel honored to have with us an eminent ophthalmologist, Professor Chintan Malhotra, with us. You're welcome, Dr. Chintan. Dr. Chintan, she is Professor Cornea, Lens and Refractive Services, Advanced Eye Center, PGIMER, Chandigarh. She was an Honorary Secretary, Chandigarh Ophthalmological Society, and a Joint Secretary of the Chandigarh Ophthalmological Society. She is a member of the Managing Committee of AIOS, that is All India Ophthalmological Society, and her areas of interest, they are Keratoconus, corneal imaging, diagnostics, refractive surgery, and corneal infections. 75 of her publications are already there in international and journal and national journals, and she is a reviewer for various journals including Acta, Ophthalmologica, Cornea, JCRS, Ocular, Immunology and Inflammation, Indian Journal of Ophthalmology, and European Journal of Ophthalmology. So you're welcome, Dr. Chintan, to this show. Thank you.
Thank you very much, sir. Thank you for the opportunity. And I'll be speaking about a topic which is very close to my heart, because herpetic keratitis is something which all ophthalmologists, whether they're cornea specialists or non-cornea specialists, come across. It's a potentially blinding disease, but on the other hand, it's a very gratifying disease as well to treat if recognized well and treated well. So we'll just go on with the case. The talk is oriented primarily clinically to be able to identify the different morphological patterns and how to treat the disease. So HSV keratitis, humans are the only known natural reservoir for HSV, and this is transmitted primarily by direct contact with infected secretions, for example, tears or saliva, or direct contact with the lesions. And which is why, because of this direct contact, the infection rates are affected directly by crowding or poor hygiene. And it's been seen that up to 90% of the population may be infected with latent infection by the age of 60 years. Not all patients who have latent infection go on to develop active infection. It's only a certain percentage of that. So coming to the clinical manifestations, we have to recognize that HSV can affect every layer of the cornea. In fact, it can affect any tissue of the eye, but since we are talking about the cornea here, so it can affect the epithelium, the stroma, and the endothelium. The stromal disease has been characterized in 2014 as herpetic stromal keratitis without ulceration, which was earlier known as immune stromal interstitial or non-necrotizing keratitis, but these terminologies used to cause a lot of confusion. So now it's simply be classified as stromal keratitis without ulceration, or one may have stromal keratitis with ulceration, which was earlier known as necrotizing stromal keratitis. And then if it affects the single-layered endothelium, then that is known as endothelial disease due to HSV keratitis. Of course, the cornea is without barriers, and any of these manifestations may occur with the other, with one component being more predominant over the other. So coming first to the one which is the most common is the epithelial disease. And in the picture that we see on the left of our screen, we have the classic lesion of HSV keratitis, which is known as the dendrite. So this is the most characteristic lesion, and it has a branching pattern, as one can see, with terminal bulbs at the end. Now, this accounted for 47% of cases in the herpetic eye disease study, which means it's nearly 50% of the cases. And this is often self-limiting. So people who are practicing cornea a little more frequently may not see this so frequently. And that's because a lot of patients may not come to us because it just gets limited by itself. The characteristic of this is that the base stains with fluorescein, and the swollen edges, which actually contain the live virus, that stains with rose bengal. So this picture needs to be imprinted in our mind. This is the classic dendrite of epithelial disease. Sometimes when these patients are either treated inappropriately with steroids because they may be presenting with just redness and watering, or if the patient is immune compromised in some way, either a diabetic who's poorly controlled or immune compromised in another way, these lesions may go on to develop a geographic pattern. So they may appear as map-like lesions, which is what you see on to the picture on the left of the screen, again the picture at top. So this is known as a geographic ulcer. So the dendrite has converted into a geographic lesion. This again is due to a live virus, but we see it's looking like a map. The picture at the bottom is also from another patient where we see a kind of a geographic lesion. Now this lesion needs to be differentiated from something else which occurs also in viral keratitis, which is known as the neurotrophic keratitis. Because we know that herpes is a neurotropic virus, it tends to affect the nerves. And because the nerves are affected, later on we get something which is known as a metaherpetic ulcer or a neurotrophic keratitis, because the epithelium does not regenerate properly. But the one that I'm talking about here, the geographic ulcers, they have classic scalloped margins, as can be seen in the pictures on the right and the left. So they have the scalloping of the margins. Whereas on the picture on the right, we see that the lesion is round. It is round and it has smooth borders. So that is a classic neurotrophic keratitis. And that happens because of impaired innervation, damaged basement membrane, because of repeated infections or drug toxicity. Why it is important to differentiate between these two is that the pure geographic ulcer, which is due to a live virus, needs to be treated with antivirals. Whereas the neurotrophic keratitis, the picture on the right, if we give excessive antivirals, they are also toxic to the epithelium and that condition can worsen. That needs to simply be treated by supporting the ocular surface with lubricants or maybe a tassoraphy at a later stage. So that is the importance of differentiating between these conditions. Coming to the next form that I mentioned, the next layer is the stroma, and so the stromal keratitis due to HSV. Now, the majority of the morbidity due to ocular HSV is due to stromal disease. While epithelial disease may be more common, stromal disease is the one which causes more morbidity. Here, immune mechanism and live virus are both postulated to play a role in the pathogenesis of these manifestations. While epithelial disease was mainly due to infective, this is due to both immune and live virus. And sometimes this can be so aggressive, this presentation can be so aggressive that it can be clinically indistinguishable from fulminant bacterial or viral keratitis. And which is why we must rule out these causes of infection, the bacterial or fungal, before we go ahead with the treatment of viral keratitis. And the treatment of stromal keratitis, depending on its pathogenesis, because it's both due to an immune mechanism and live virus, treatment has to be treated with both antivirals as well as with steroids. Of course, depending on which component is more, it has to be a fine balance. Sometimes antivirals will have to be more and sometimes steroids will have to be more. And I'll come to that in the next slides. So this is the classic case of a presentation where a patient will present with stromal keratitis without ulceration. Interestingly, this was a lady who was being treated before she came to us for 2 months as a case of sometimes bacterial, sometimes fungal, because she had a hypopion. So I would just like to point out that when we have a hypopion, although that is more in favor of bacterial or fungal, sometimes viral can present. What is characteristic here is that we see stromal inflammation, and that is the hallmark of stromal keratitis in HSV keratitis. This has a very classic granular appearance on the slit lamp once it's seen. It's difficult to actually mistake it for anything else. And this is often associated with this arborizing pattern of vessels. We see this one stem coming from the bottom and it's kind of arborizing in a tree-like fashion. So this is a patient who's classic stromal keratitis without ulceration. Then we have another manifestation. This was a young male. He coincidentally gave a history of something falling into his eyes. And again, he was being treated with a combination of antibacterials and antifungals without worsening. So the clue I would like to give here to our viewers is that if we see in the large picture on the left, we have an area of infiltration. So there is dense infiltration in the cornea. But surrounding that, there is a large area where the cornea appears edematous. And that should make us suspect that the endothelium is involved in addition to the stroma, and which is why we have so much of edema, and which is why this could be a viral disease. But I would again like to reiterate, because without 100% surety, if one has not seen so many cases, one may not be able to differentiate. So one may think viral, but be sure to rule out bacterial and fungal infections. And so should send scrapings for gram stain and KOH wet mount, and only then proceed with treating it as viral if those are negative. So just those are the clinical manifestations, and just to give an idea of how these patients do if they are treated well. So in the first case, we treated the patient with systemic antivirals and steroids, systemic acyclovir, which I will come to again later. And so the picture on the left is showing us the image after 2 weeks of antivirals and steroids. And the patients with the cornea cleared up, the vision improved from hand movements to 636, which was also partly because she had a significant cataract. And the hypopion completely disappeared. So that is our clinical validation of the fact that the patient had viral keratitis which responded. However, a word of caution here. One should not get excited because most of it has resolved. One should look at this slit lamp closely, because while everything had disappeared, the stromal edema was persisting, which is shown by the yellow arrow. So which means that the stromal component has disappeared, but the endothelial component is there. And so steroids were continued for a little while longer till the stromal edema also disappeared. The second case, the one which was not responding to antibacterials and antivirals while being treated somewhere, so again was started on steroids, a combination of steroids and antivirals. After, of course, we getting a gram stain and KOH negative. And we could see here that again, we can see that the infiltrate has decreased so much rapidly after 3 days. The vascularization has decreased. So we look at multiple things. We look at the infiltration decreasing. We look at vascularization decreasing. We look at the stromal edema coming down, and all three have come down. So till the epithelial defect healed, we treated with systemic antiviral and systemic steroid. You want to avoid topical steroid till an epithelial defect is there. But once the epithelial defect had healed, we followed by topical steroids till the resolution of the stromal inflammation. Now the picture at the bottom where the white arrow is shown, this is just in retroillumination, trying to show that even if a patient may look okay on diffuse illumination, on retroillumination or a fine slit, one can see cellular reaction in the stroma. And that again as an indication that treatment should be continued. Otherwise, you will have incomplete resolution. Then coming to the third manifestation where the endothelium is involved, that's known as the endothelial keratitis or endotheliitis. Now this can occur in different forms, and this can be referred to as disciform endotheliitis if the endothelium is affected and the edema is in a disc-like pattern, or it can be diffuse endotheliitis. So This was again a patient, a young girl around 20-year-old, who was actually referred to us for a keratoplasty, for a corneal transplant, because whoever saw her thought that this is a corneal opacity. It's right in the visual axis, and which is why this has to be treated. But here again, would like to say that we should be careful. Whenever we think of a stromal opacity, we know that the opacity, the cornea is thinner, whereas in endothelitis, when the endothelium is inflamed, that leads to dysfunction of the endothelium, and that leads to corneal edema. So stromal edema is the hallmark of endothelitis. And because it is an endothelitis, we know that it's an inflammation, so we can expect keratic precipitates on the endothelium. But these keratic precipitates underlie the area of edema, and they may become visible only later once the edema resolves partially. So this is to show this patient. The picture at the bottom on the left shows the slit examination, and we see that the cornea is thick here. If one is confused, one can compare the cornea in the center with the cornea in the periphery. Normally, the cornea in the center is thinner. So if you see cornea in the center which is thick as compared to the periphery, which is what is being shown in the picture on the right at the bottom, then one is sure that a central thicker cornea is edema. And so this was a case of, again, presumed HSV keratitis. Definitive, one could only say if one gets a PCR or a culture, but those are not routinely indicated in clinical practice, and those are not available to everybody as well. So this is a clinical diagnosis, and once we treated this patient with steroid, the edema resolved significantly. Unfortunately, I don't have the follow-up picture of this patient, but I will show you another patient. So this is a patient this was a single-eyed lady who presented to us with sudden diminution of vision over the last 12 to 14 days. Once we see her clinically, at presentation, there is severe corneal edema. The picture on the left again is showing that, with only around 1/3 of the cornea which appears clear supero-temporally. So this patient has severe clinical edema. Make a close slit, and one could see a few KPs, but one can just guess at that. Again, in viral keratitis, corneal sensations are diminished. So I don't want to reduce the importance of that. That is an important fact. Any corneal lesion, we must test corneal sensations. So corneal sensations are diminished, and the patient has not undergone any surgery. So it's not an edema which is due to surgery. So this is the kind of picture which can appear with diffuse endotheliitis due to HSV keratitis. The vision was counting fingers close to face. So again, this patient treated with 5 days of steroid and oral acyclovir. And we can see in the picture in the middle, the edema has reduced significantly, and the keratic precipitates are now visible under the area of the edema, which is shown by the small yellow arrow. And 10 days later, we can see the picture at the bottom. The vision had improved, and it's 6/12 with significant clearing of the edema. So I would just like to point out here the differences between stromal versus endothelial disease. Why that is important is that the clinical course and the prognosis for the two conditions are entirely different. Stromal disease has a worse prognosis. It requires treatment for a much longer time with a longer duration of steroids, along with the associated risk of steroids like cataract and glaucoma, and it tends to recur more. So there you have stromal infiltration, and one may have some degree of edema because the endothelium is also partly involved, but the edema is less. And so what we see in the top picture is a classic stromal keratitis with some edema. On the other hand, when the endothelium is primarily involved, the picture at the bottom, this stromal edema is much more marked, and the infiltration or the cellular reaction in the cornea is much less. Endotheliitis responds more beautifully to steroids than does stromal keratitis, and which is why it is important to distinguish between these two conditions. If these conditions are not recognized, the patients can have long-term sequelae. For example, repeated attacks of stromal keratitis can present with deep vascularization, and one can have, because these vessels are leaky, they are not mature vessels, one can have repeated attacks and lipid keratopathy. And the cause of these is repeated attacks of stromal disease which have been inadequately treated. On the right, we see a picture which shows sometimes we may see a patient just like this, and this is classically known as the footprint scar. That means the disease was there and it left its footprints of epithelial disease. So which is why it is important, and why this is important is because, like the picture on the left, this is a patient now who would require keratoplasty for visual rehabilitation. And keratoplasty we know is associated with its risks of a corneal rejection, a corneal failure. And so we've converted a disease which, if it had been recognized properly and treated in time, the risks, the chances of a keratoplasty would have gone down significantly. And that is the importance of recognizing the various manifestations of the disease. So that was the clinical presentations of epithelial disease, stromal disease, and endothelial disease. Coming to the treatment. So we need to know that each manifestation is because of a different pathophysiology, and which is why we need to treat it differently. So epithelial disease is mainly because of live virus that needs to be treated with antivirals. They may be topical, they may be systemic. Stromal and endothelial disease are both believed to be due to a combination of live virus as well as immune mechanisms. So there we treat with a combination of both antivirals and steroids. And these antivirals and steroids have to be given initially in a higher dose, which is known as the therapeutic dose, and then in a prophylactic dose. So we'll do this. So for example, if we have an epithelial disease, like the lesions I showed in the first few slides, whether it is dendritic or geographic, most of the patients would respond to topical antivirals for a period of 10 to 21 days. So the most commonly available in our country is ointment acyclovir, which we give 3% 5 times a day. That would need to be given for a period of 7 to 10 days. Or if the lesion is very large, maximum for up to 2 to 3 weeks. Usually it's not required beyond that. We now also have ganciclovir gel available, which works in the same doses 5 times per day. The advantage of ganciclovir gel is that it is more friendly to the cornea. So if a patient already has a poor corneal surface, for example, dry eye or some drug toxicity, then ganciclovir gel would be a better option. So while in majority of the cases, this topical steroids would work, oral antivirals may be needed in certain situations. There would be, for example, if an elderly person who's living alone and has inability to use topical medications, has intention tremors, for example, that person would be better treated with oral antivirals. Pediatric patients may sometimes be refractory to topical medications and they need to be treated with oral antivirals. Like I mentioned, if a patient has poor ocular surface, then oral antivirals may be needed. And for prophylaxis, to prevent recurrence prior to and post-surgery, oral antivirals. Now, the oral antiviral, the therapeutic dose, of course, it would have to be by weight. But for most adults weighing between 50 to 60 kgs, the acyclovir 400 mg 5 times a day is the usual therapeutic dose, or valcyclovir 1 gram TDS. But again, I would say that majority of the patients would respond to topical treatment. Of course, this has to be with supportive treatment like lubricants. Then if we come to the second manifestation, which is stromal keratitis without ulceration, the example I showed earlier of the stromal inflammation with hypopyon, here immune mechanisms are believed to play a bigger role than live virus. So here we target the immune mechanism first. We give steroids in therapeutic doses. And here, because we don't have an epithelial defect, we can safely give topical steroids. For example, prednisolone acetate 1%, 6 to 8 times a day. And now the important thing is that these have to be tapered slowly. These have to be tapered over 10 weeks or more, depending on the disease activity. Rapid tapering will lead to a recurrence of the disease. Plus, we combine this with a prophylactic dose of, like I mentioned, the therapeutic and the oral doses. We don't give the full dose of the oral antiviral. We give the prophylactic dose of the oral antiviral. For example, acyclovir 400 mg twice a day would be sufficient. On the other hand, if we have stromal keratitis with ulceration, which was earlier known as the necrotizing, now this can sometimes be a very sight-threatening disease in the sense that the cornea can rapidly go into melt, and you can the tectonic stability of the eye can be affected. Here, the live virus is believed to have a greater role than the immune mechanism. So here we give the therapeutic dose, the higher dose of the oral antivirals, that is acyclovir 800 mg 3 to 5 times a day, or valcyclovir 1 gram TDS for 7 to 10 days. So we give this initially and then shift to the prophylactic dose of the antiviral. While we are in the beginning, if we feel that the inflammation also needs to be controlled as quickly, so till the epithelial defect is there, we may give systemic steroids, which can't be said for every case, but it has to be on a case-to-case basis. Once the epithelial defect heals, then these steroids can be started topically. If the endothelial keratitis is there, here again live virus is supposed to play a large role. And here we give therapeutic dose again of oral antivirals like I mentioned earlier, and a therapeutic dose of topical steroids, which means spread about 6 to 8 times a day. I apologize for that, followed by a therapeutic dose of topical steroids as well. The key point here is that steroids should be used as little as possible, but as much as necessary. So we should be careful that steroids can cause glaucoma as well as cataract. So we should be cautious in using them. We should keep the patient's IOP in mind. But if we use them too less, then also we are doing the patient a disservice, and which is why they should be used as little as possible, but as much as necessary. My last couple of slides, I would like to mention that HSV keratitis is seen in children, but it is often misdiagnosed. So as compared to adults, children are likely to have disease which is more severe and has more implications. So bilateral disease is more common in children as compared to adults. Combined epithelial and stromal disease is seen more often. And the recurrence rate is much higher in children in the first year after the first episode, which is 40 to 50%, vis-a-vis 18 to 30% in adults. Also, children have a more robust inflammatory response leading to scarring. And of course, if we have scarring, that further leads on to amblyopia if it's in the visual axis. And they have a higher chance of being misdiagnosed. So we need to be aware that HSV keratitis can occur in children. Any time a patient presents with something which we are doubtful about, one should stain. Fluorescein staining is the simplest of things which can be done. And my last slide here is something which we don't think about so frequently. We think of antifungal resistance, we think of antibacterial resistance, but we don't think of antiviral resistance. We should think of that because up to 6.5% of immune-competent patients with HSV keratitis, and I mention here immune-competent patients, can be resistant to acyclovir. And that is why? Because some of the host enzymes as well as the enzymes on which the virus acts, the drug competes, those compete with each other. So patients who are resistant to acyclovir are also resistant to valcyclovir, galcyclovir and famcyclovir, and they do not respond to these drugs. So they have to be treated with either foscarnet, cidovir or trifluridine because there's no cross-resistance seen with these drugs. How does one suspect cross-resistance in the absence of lab testing is that if a patient has frequent history of oral steroids and a frequent history of recurrences despite being on adequate oral prophylaxis, in those cases, one should suspect antiviral resistance. So, thank you very much.
Thank you, Dr. Chintan. So I'm sure this will benefit this presentation, pictorial presentation is really good. And this will benefit general ophthalmologists as well as MDMS students of ophthalmology. And it is really one of the slides that showed the think viral, but be sure to rule out bacterial and fungal infections. That is very important. And we must send scrapings for gram stain, KH, wet mount before before treating the patient.
Absolutely.
And another thing, important thing is that we must see the corneal sensitivity
Yes.
before we make the diagnosis. So it is wonderful. Thanks a lot, Dr. Chintan. And if there are some questions, you can even answer through email if you have any question.
My pleasure.
Okay. Thanks a lot.
Thank you.
It was an absolute pleasure listening to you. Very well presented session. A lot of takeaways for the audience. This brings us to the end of this session. Thank you so much, Dr. Chintan and Dr. Rakesh, for your time and effort in putting together this interesting session. To our dear viewers, thank you so much for attending this session. Do share any more questions if you have. Until we see you again, take care and happy docplexing. Thank you.